Okay, we'll get started probably in like 30 seconds so that we can make sure that we get through all of the information that we want to get through today and let you get back to work on time. And just as a reminder, before we get started, if you want to put your questions in the Q&A box, and we'll either get through them during the talk or at the end of the talk. So please put them in the Q&A rather than the chat so we can try to address them. Okay, let's get started. Thank you all for joining. This is a talk about COVID-19 outpatient therapeutics. And I have my partner in crime here, Dr. Rupali Jain, who is also on the COVID therapeutics team. And we're going to be going through what is available for outpatient treatment and how to give it to someone and going over it through case by case. We don't have any financial conflicts of interest. So our learning objectives today are to review the available outpatient therapeutics for COVID-19 disease, review eligibility and contraindications to therapy, review our current UW medicine workflows and for ordering this therapy, and then talk briefly at the end about treatment for preventing COVID-19 disease. Next slide. So we have all been in it for a few years now. Unfortunately, we haven't had the opportunity to really be able to be involved as outpatient providers to offer therapy. So our first treatment, Remdesivir, which has been available for some time now, was only an inpatient therapy. Only in the last year and a half have we had therapeutics in the outpatient setting. And those have been often limited by supply and constraints in terms of administration, only being IV, to really not be in the purview of most of our ambulatory providers to even consider offering. So now, fast forward to where we are today, we actually have a few options for outpatient therapy, and those are highlighted in orange. Unfortunately, we have also had some taken away as this virus has evolved and variants developed to make some of our previous therapies ineffective. So we're always on our toes in terms of keeping up with therapeutics to make sure that we're using the right ones for our patients. Next slide. So I just wanted to briefly mention emergency use authorization versus FDA approved. So the therapeutics that are available currently are all except one, and for the outpatient setting are authorized for emergency use only. They're not FDA approved. The only treatment we'll talk about briefly that is FDA approved is Remdesivir. The other therapeutics are for emergency use authorization. That means that there's not that these were authorized because there was no adequate approved medical therapy available, and because of the pandemic, which is an emergency, and we wanted to be able to provide access quicker to patients to really try to change this pandemic and limit the number of people hospitalized and dying from this disease. It can be revised or revoked. And so we have seen some instances where, and we'll talk about one of them, where there has been some revisions and there has been some revoking of medications, as I mentioned, because they're ineffective due to the variants that are circulating. And most recently, sotrovimab, which is a monoclonal antibody, was revoked as it did not have adequate activity against the BA.2 variant, which is circulating. One of the things to note is that we're still gathering information when medications are under emergency use authorization. So if providers do know patients have adverse effects or severe side effects from these medications, it is our responsibility to report these adverse drug reactions to the FDA so they can have this information when they review these medications. Next slide.
Okay, so we've heard a lot of terms such as EUA, and so we're going to spend a little time talking about what an EUA indication is versus the NIH tiers, because we've used this prioritization in order to help determine who will benefit the most from therapies. So as Shireesha was mentioning, earlier in the pandemic, we had very limited supplies of certain medications. And with this decreased supply of medications, the NIH, we leaned on the NIH to help us determine who will benefit the most within these eligible groups that were studied. And so when we look at the prioritizations, there are 4 tiers. Tier 1 are the patients that are immunocompromised, that are not expected to respond to the vaccine. And in addition to these patients, we have also unvaccinated individuals that are aged above 75 or aged above 65 with clinical risk factors. When we move through the tiers, we can also see that tier 2 also includes unvaccinated individuals who are at risk for severe disease. And tier 3 and 4 are vaccinated individuals that are at severe risk for or at risk for severe disease in older patients greater than 75, and anyone that may be under 65 in tier 4 with clinical risk factors. Now, these are important to kind of use as a framework as we're talking about some of the clinical data, as well as understanding which patients may benefit the most. So as we promised, this is going to be a case-based learning. And so our first case is PY, who's a 47-year-old who calls your office after testing positive. They endorse COVID symptoms such as new cough, fever, headache, as well as feeling shortness of breath while walking around their apartment. Their pulse ox is good at 97. They're vax and boosted, as well as their symptoms started 2 days ago. They currently have no medications. So the questions we need to ask is, what is the patient's disease severity at presentation? What are the risk factors for severe disease? And is this patient eligible for therapy? So some of the checklist that's within the EUA that we should be considering when evaluating our patients is some of these minimum criteria. One is a positive SARS-CoV test, whether it's antigen home test, a PCR, as well as the patient should not be hospitalized. In addition, the patient must have symptoms, and the symptoms must be within 5 to 7 days. And this is because these medications have been studied within this time frame. And lastly, we will look at the risk factors for severe disease, which we'll talk about. In addition to looking at the risk factors for severe disease, it'll be important for you to know the medication list as well as the renal function in order to evaluate patients appropriately. So when we think about COVID-19 disease, it is quite a big spectrum of disease. It can range to mild to moderate disease to severe and critically ill patients. More recently, we've been seeing more mild to moderate, and these COVID is when you have COVID symptoms when the mild classification, the COVID symptoms are very typical of a URI, so fever, cough, headache, diarrhea, but you have no shortness of breath or abnormal chest imaging. When you move to moderate, the patients may have some signs of lower respiratory tract disease, but they maintain good oxygen saturation on room air. When we think about mild disease, it's important to note that you need to have symptoms in order to be classified as mild disease. So we are seeing a lot of patients that have pre-op testing that may not have symptoms, but they may be at high risk. But without symptoms, they do not have, they don't meet the criteria for disease severity. So when we drill down to the risk factors for disease progression, we really lean on the CDC, who's compiled the data for the underlying conditions that may predispose patients. You can see here graphically, this is a composite from a large study that over 500,000 patients done in the beginning of the pandemic. And you can see here that patients that are above 65 do have a higher risk for disease progression. In addition to that, we see conditions such as diabetes, obesity, chronic kidney disease, as well as pulmonary disease and heart disease and neurocognitive disorders that can be risk factors for severe disease. Other risk factors that have been noted include immunosuppression, cancer, pregnancy, recent pregnancy, polysubstance abuse, obesity, and chronic liver disease. It's important to note that all of the EUAs for the drug actually link to this website that's here at the bottom that really go through the underlying conditions that place patients at higher risk. So I encourage you to review this. In addition to not only having a comorbid condition, it's also the number of comorbid conditions also increases your risk. So with this, we are going to review several options for outpatient therapy, and really with the note that our therapeutic goal and all of these agents have been studied in order to help patients avoid hospitalization and death at 28 days. And so as we go through each of these agents, Paxlovid, IV Remdesivir, Beplatuvimab, Molnupiravir, you're going to see this recurring theme of this is what we're looking for effectiveness for these therapies. So when we go back to our case, our patient presented with mild to moderate COVID. The patient currently does not have any risk factors for severe disease, so this patient would not be eligible for therapy. They do not meet EUA criteria. So with this, I'm going to pass it to Shireesha to do a more complex case.
Yeah, so we're just switching things up a little bit with this person who is this similar individual, similar symptoms, relatively short onset of symptoms 2 days ago with new cough, fever, headache, but does have underlying Crohn's disease. He's vaxxed and boosted. He has well-controlled symptoms because he's on infliximab for disease control. So we want to think about it in the same framework. This person has a relatively short onset of symptoms. He is symptomatic. So what is this patient's disease severity at this presentation? It's mild to moderate. What are the risk factors for severe disease? And in this individual, his infliximab does cause him to have immunosuppression. And so this is being a main risk factor for his disease progression. So is he eligible for therapy? Yes, he is eligible for therapy. So then the next step is, well, of those options that Rupali outlined before, what is our go-to, our default that we should consider, and then think about why he can't, or this patient can or cannot get it. So Paxlovid is really our go-to, and I'll talk about why that is. It was, the indication is for non-hospitalized patients with mild to moderate COVID disease who are at risk for severe disease, progression to severe disease, symptom onset less than 5 days. It can be given to pediatric patients, but our UW Medicine Therapeutics program does really focus on adult patients. The mechanism of action, it's a protease inhibitor, which does stop viral replication, but important to note that it has a medication called ritonavir that we know well from treating people with HIV. It's an antiretroviral, but its main use is actually to affect the metabolism of drugs, to allow lower doses of drugs to be used and to be dosed less frequently. So that's really, it's a booster, a pharmacologic booster. The dosing for Paxlovid is 3 tablets of this fixed dose combination twice daily for 5 days. Next slide. And really the data that led to its authorization are from this study that involved over 2,000 patients looking at people who are not hospitalized with mild to moderate disease and at least one risk factor for developing more severe disease and symptom onset within 5 days. So it's a randomized controlled trial, and the primary outcome was hospitalization or death at 28 days. And important to note is that there was some key exclusion criteria, and namely, if they'd received a COVID vaccine, they were not included in the study. Also, pregnant and breastfeeding women, they are often not included in studies either. So next slide. What I want to highlight here is that it is a very highly effective medication in these patients with mild to moderate disease and risk factors. 88% lower risk of developing hospitalization or death in the Paxlovid group versus placebo. So significant benefits. Of note, things that when you're counseling patients about Paxlovid, I want to mention that GI side effects, which is why on someone with Crohn's, you'd really want to check if their GI symptoms are controlled, because giving Paxlovid can definitely worsen those symptoms. So thinking about diarrhea, nausea, vomiting. The most common one we'd say is altered taste or dysgeusia, where patients have an unpleasant taste in their mouth. And so just letting patients know that that may be a side effect so that they're not surprised. Next slide. So when we're thinking about using Paxlovid and you've identified this patient as being eligible, what we really want to do next is a drug interaction checker. So as I mentioned, ritonavir, it's beneficial to use as a pharmacologic booster, but it can be detrimental if they're on other medications that could be inhibited or actually decrease, the metabolism decreased. So the Liverpool drug interaction checker, and there is actually, I'll show you a link to it from the order itself, has medications that are contraindicated that you would want to avoid Paxlovid. There are some medications where we can just safely hold. And so for instance, patients on statins, and another one is sildenafil if they're not using it for pulmonary hypertension, if they're using it for erectile dysfunction, if they can hold those medications, then you can go ahead and do Paxlovid or consider reducing the dose of those other medications potentially. But you definitely want to avoid Paxlovid in certain patients where the risk of the drug interaction is pretty significant, and namely patients who are transplant patients who are on tacrolimus or cyclosporin or sirolimus, or patients who are on DOACs, where the risk could be significant. Also, for people of childbearing age, you want to think who are on oral contraceptives. There is also significant drug-drug interaction. So you would want to counsel about an additional method such as barrier protection while they're on Paxlovid. Next slide. So for this patient, disease severity, mild to moderate, the risk factors being immunosuppression, this patient is eligible for therapy. And we've checked for what we want to do is check for drug-drug interactions. This patient, fortunately, is only on infliximab. So you put in the order, and this is, we'll walk you through how to put in the order. So this is the workflow that's currently that we have at UW Medicine for Paxlovid. It reviews the eligibility criteria again. And then if you have any questions, there are links to the right that you can link to. And so someone had a question in the chat about NIH guidelines. There's a link to that there. And then also the EUA fact sheet, as well as our own institutional guidelines. Once you've determined they meet eligibility, you want to make sure that there has been a review of their kidney function. And so want to ensure that their GFR is over 30, otherwise Paxlovid is contraindicated. Then, and then there is a dot phrase. When you're contacting the patient, what I would do is enter a telephone note and put in the COVID-19 oral therapy assessment, go through it, and go through the EUA fact sheet. You can even send a link to the fact sheet via MyChart in that same encounter, which is what I've done. And then for patients who are using our own pharmacies, UW Medicine Montlake, Outpatient Pharmacy, and Harborview both do curbside delivery for patients to make it even easier. They don't have to come out of their car with their COVID. They can just get the prescription dropped off to their car. So next slide. If they don't live immediately within close distance to these pharmacies, this website gives, you can enter in the zip code for the patient, and it will identify pharmacies that carry the oral antivirals for you, and you can send that prescription there. We did hear from the Department of Health just last week that the supplies of the oral antivirals are significantly increased, so there should not be a supply issue when you're sending prescriptions to pharmacies. Next slide. So here's the order. So when you put in Paxlovid in the Add Order tab in Epic, what you will get prompted to do is pick either the full dose for patients with GFR 60 or over, or reduced dose with the patient's GFR is 30 to just less than 60. And this is important to note to pick the correct dose. Once you've picked the correct dose, and it prompts you again that for GFR less than 30, it's contraindicated, and it prompts you again here in the ordering instructions just so you know. And it also, for patients with severe hepatic impairment, it's also not recommended. And as reference links, in case you couldn't find the fact sheet very easily, this one, the order sheet, the order itself has a link to the fact sheet, as well as the drug interaction checker if you didn't go to the workflow for whatever reason. And so then you've entered the prescription, and then within the prescription itself, it prompts you to acknowledge that you've reviewed the EUA and that you've reviewed the drug interactions. And then you can go ahead and select the pharmacy of choice and hit accept and order the medication. So this patient can get Paxlovid.
Okay, so now we'll move on to the same case, but some new iterations. So this is a 27-year-old individual who calls her office after testing positive for COVID-19. They are 24 weeks pregnant, and they endorse the same symptoms as the other patients have, and the symptoms started 2 days ago. The patient is COVID-19 unvaccinated, currently has no other past medical history, BMI is 25, and they're only on prenatal vitamins. So again, going to our 3 questions that we ask: what is the patient's disease severity at presentation? This is mild to moderate. What are the risk factors for severe COVID-19? This would be pregnancy. And is this patient eligible for therapy? So yes, this patient would be eligible for therapy based on the information that we provided here. And so we would look through, we would go through the workflow for Paxlovid for this patient. Some of us may ask, or our patients will ask, is this safe in pregnancy? The Society of Maternal Fetal Medicine put out a statement early in December that supports use of treatment in pregnant patients that meet clinical qualification. In addition to this, the NIH guidelines also endorse using Paxlovid in pregnant patients. And this is really based not only on this statement, but animal data that shows safety. In addition, we have a lot of experience with using ritonavir in our HIV population who are pregnant. Now, some questions that may come up as pregnant patients may be vaccinated, but they may have other risk factors such as diabetes, hypertension, or higher BMI. And these patients may opt to have therapy. And this we would recommend having a shared decision conversation with this patient to understand the risks and benefits for that individual. So now we'll move on to a transplant case. So again, this is PY, who's a 57-year-old who calls her office. They endorse new cough, fever, headache, but their past medical history includes liver transplant in 2012. The BMI is the same, symptoms started 2 days ago, but the medication list includes tacrolimus, aspirin, losartan, rosuvastatin, and mycophenolate. From what Shireesha was talking about earlier, the tacrolimus is one of those key drugs that may not work for Paxlovid. So our default option may not work for this patient. But before we go into that, let's review the 3 questions. What's this patient's disease severity at presentation? Again, mild to moderate. And this patient has immunosuppression as one of their risk factors. So this patient is eligible for therapy, but because of the tacrolimus, our default option of Paxlovid may not be appropriate. So again, we go to our options here, the NIH, and we move to bepirovirsen, which is a monoclonal antibody. And again, this will be our next option for organ transplant patients. So what is this? This is, again, studied in the similar type patient populations, non-hospitalized patients with mild to moderate COVID-19. Again, in patients with a high risk for progression, in patients greater than 12 years old and 40 kilos, and the symptom onset has to be within 7 days. The mechanism is similar to other monoclonal antibodies in that it binds to spike proteins on the SARS-CoV and does not allow for it to enter the cell and have viral replication. The dosing is 175 milligrams, and it's just given as a one-time infusion or an injection. It's important to note that it is not authorized for patients that are hospitalized due to COVID-19, patients that require oxygen due to COVID-19, or have an increase in oxygen requirement due to COVID-19. And this is really because in the earlier studies, they found that when they gave this to patients that were farther along in the disease progression, it actually may worsen clinical outcomes. And so we really avoid using it in these populations. And so the data that that led to its approval, as you saw, it was the 4th monoclonal antibody that we've used over time. And so this data is actually from a phase 2 study earlier in the pandemic, where they compared it against other monoclonals. And it did show in the secondary outcome that the hospitalization or death from any cause was lower. And so really we are borrowing, because this is a phase 2 study and not as many patients, we are borrowing from the other monoclonal antibodies and the demonstrated efficacy. And the real reason why we switched to bevletovimab is really the in vitro data with the Omicron surge, that it does have activity in vitro. And so for our transplant patient, then we would recommend, since Paxlovid is not an option, we really want to think of other options such as IV bevletovimab. So we would go to the COVID-19 resource page that's found here. And you would link to the REDCap referral so that the UW Medicine COVID-19 team could review the patient case. Our team will discuss the therapy with them, document in the chart, review the EUA material, as well as schedule the patient. If the patient doesn't qualify, we will notify the provider who put in the REDCap and notify them that they don't qualify for therapy. So going back to our case here, this patient will get IV bevletovimab. You have submitted a REDCap, and the UW Medicine COVID-19 team will call and schedule the patient.
All right. So this is a similar person who has drug-drug interactions that we'll go through. So similar stem here, 2 days of symptoms, positive COVID test, having mild to moderate symptoms, and vaxxed and boosted. So has a number of comorbidities and is on apixaban. So this gentleman has mild to moderate disease, risk factors for severe disease. Is this patient eligible for therapy? Yes. What makes this person, so the problem with the default Paxlovid is that there's a significant drug-drug interaction similar to the transplant patient. But how is this patient different from the transplant patient? I think that's the key when we're thinking about our framework for treatment. So this patient is not a tier 1 patient like the prior patient because they don't have significant immunosuppression. So in the NIH framework is a tier 3 patient. So next slide. So what options do we have if we cannot use Paxlovid? And because of supply and staffing constraints for bebtelovimab, and really, does this patient need that monoclonal antibody for treatment? Because as a tier 3 or 4 patient, we can offer molnupiravir. So molnupiravir is another oral antiviral, again, studied in similar patient population for non-hospitalized, mild to moderate, at risk for disease progression. That's the indication. And it's in terms of the guidance for use, it's when alternative treatments, specifically Paxlovid, are not available or clinically appropriate, like bebtelovimab necessarily. Its dosing, it's also 5 days, 4 capsules twice daily, and it is not recommended during a pregnancy given concerns for complications with the fetus. Next slide. So this study had over 1,000 patients randomized to molnupiravir or placebo with patients with at least one risk factor who were in the outpatient setting and symptom onset within 5 days. And what's nice is all the outcome measures are the same. So hospitalization or death by day 29. And you can see here that in patients who received molnupiravir, they did have a lower hospitalization rate and lower and hospitalization for any cause or death of any cause. And the relative risk reduction, though, was 30%. Versus, as you can recall, with Paxlovid, 88%. So this medication is not as effective as Paxlovid, but does still have some benefit for these patients who may be at lower risk than our tier 1 and tier 2 patients. Next slide. So similar to Paxlovid, we at UW Medicine Therapeutics team do have a workflow for molnupiravir, and you can see it reviews the eligibility criteria and walks you through the DOT phrase as well, DOT molnupiravir, and has the links to the FDA fact sheet in English and in Spanish. And similar to Paxlovid in terms of our pharmacies, our Harborview Pharmacy and our outpatient pharmacy at UW Montlake do carry it and offer curbside delivery. There is also an option for Northwest prescriptions on the Northwest campus as well. And that same database for locating pharmacies in closer to patients' homes can also be used to identify molnupiravir. Next slide.
This is me. So PY, now this is another case, but we're going to talk about the last therapeutic option that we can use. And PY is a 67-year-old patient that calls your office with new headache and dizziness, and they ran out of their hypertension medications about a week ago. You instruct the patient to come to the ED, and they are admitted. Upon further questioning, the patient does note to have a new cough for 2 days and is found to be COVID-19 positive. They remain on room air and do not need supplemental oxygen. This patient is vaxxed and boosted, but does have some high risk characteristics for progression to severe COVID-19. Oops. So let's go through the options that are available for this patient. And so one of the studies we wanted to highlight is IV Remdesivir. Now, again, as Shireesha mentioned, this drug we mainly used in the inpatient setting, and we've really shifted focus. And this nice study published in New England Journal really showed us that we can use it in the outpatient setting or for these patients that don't require oxygen. So again, the indications are very similar to what we heard previously. So not hospitalized with mild to moderate COVID. They also have risk factors for severe progression. They must have symptom onset within 7 days. And as we know, Remdesivir is an intravenous antiviral that inhibits the RNA-dependent polymerase. It is available IV as a 3-day course. And this was studied in, again, that same population with the same primary outcome of looking at COVID-19 related hospitalization or death. And so again, when we look at the hazard ratios and the Kaplan-Meier, you can see here there is a demonstrated difference between the Remdesivir and the placebo group with a risk reduction of close to upwards of 85%. So what can we give this patient? This patient is mild to moderate. They have risk factors. They are eligible for therapy. And if this patient is admitted to the hospital, we can give them IV Remdesivir for 3 days. Unfortunately, we cannot offer this in our outpatient infusion clinics because of the space and availability as well as staffing to give 3 days of consecutive. So this would be an option for patients that are admitted for high risk or admitted and for non-COVID reasons and have a high risk for progression to severe disease.
Great. We'll switch gears to pre-exposure prophylaxis. And I do want to, there are a number of questions in the Q&A that I do want to be able to get to. So I think we'll have time for questions after this. So next slide. So we have one medication currently that is FDA authorized for emergency use. which is Evusheld. Its indication is that for immunocompromised patients or those who are unable to receive vaccine due to a severe allergy, for instance, and no known COVID exposure and they're COVID negative. So this is not for treatment or post-exposure prophylaxis, meaning if you had a high-risk exposure, you would not give this. This is for pre-exposure prophylaxis. So it is a neutralizing monoclonal antibody that provides passive immunity. And so really thinking about it in our immunocompromised patients who may have gotten their vaccines, but just could not generate a good immune response to them. It is given, the dosing is 300 milligrams of each of those drugs, and given at 2 separate 3 ml injections, so quite a bit of volume. And its duration of protection is actually unknown. Initially, it was thought to be going to be every 6 months, but we have already seen a change in the EUA. It was previously 150, and then a couple months after it was authorized for emergency use, AstraZeneca, who makes this drug, actually asked for a revision to increase the dose to 300 and 300. Next slide. So the data for that led to its authorization was from the PROVENT study, patients who had no known exposure and unvaccinated. So again, a lot of these therapeutics studies are done in unvaccinated individuals. And this is for adults, so placebo versus Evusheld, and I'll note that this was the lower dose previously, and the primary outcome was incidence of COVID-19 positive case at 6 months. And what it did show was that there was a 77% reduction in symptomatic COVID-19 disease and a 69% reduction in COVID-19 disease or death from any cause. You can see that nicely in this Kaplan-Meier curve. Next slide. So at UW Medicine, we had, so this was authorized for emergency use at the end of December, I believe, of 2021. And we were really in the thick of the Omicron surge. And so we had a little bit of a delay really ramping up this program as we were focusing on our treatment of COVID-19 disease rather than the prevention. But over the last couple of months, we've really ramped up this program. We have 6 clinic administration sites with a total of about a capacity of about 200 a week. And we're exploring additional sites, including a more of a mass site to be able to get a larger volume of patients in. We've also started administering at UW Montlake for transplant patients during their inpatient stay, and that started at the end of March. SCCA is also offering a similar option for patients with lymphoma and those who have received a bone marrow transplant. So in the last few weeks, we have actually been sending letters out. We sent out letters to patients of all of our severely immunocompromised patients, directing them to call our number if they are interested in discussing and pursuing this prophylactic medication. And then they can just self-attest to meeting eligibility. And then what happens is similar to when we had a shortage of vaccine or a backlog of vaccine patients who needed to schedule, they're placed on a wait list or a callback list. And then our COVID-19 therapeutics nurse team actually will call them and schedule them for Evusheld. Just a note, if your patients are eligible, they may be on the wait list for a couple of weeks, depending on appointment availability. We at UW Medicine, we have we have over 10,000 patients who probably meet this criteria for getting Evusheld, because we are a large transplant center and we have a number of patients through MS clinic or rheumatology clinic that are on immunosuppressive medications. So it will take some time to get through them, but that's what we are doing. If there are any questions that and our therapeutics team is actually continuing to do targeted outreach to a limited English proficiency population, and then providers can continue to refer patients directly, and there is a workflow on the COVID-19 site on how to do that. If there are any questions about qualifying criteria, Caroline Walker is our point person. She's the lead for the Evusheld program, and her email is listed there. Next slide.
Okay, so this is a summary slide of all the information that we talked about. So starting at the top with Evusheld, again, this is meant for pre-exposure prophylaxis, and it showed that it had 77% reduction in symptomatic COVID. It is available outpatient, and it is also available inpatient at the Montlake campus. IV bebtelovimab, we talked about it being a monoclonal antibody. We're mainly using this for those patients that are heavily immunosuppressed or unvaccinated with clinical risk factors. Again, this also, inferring from other monoclonals, had similar risk reduction in hospital and death. This is available in the outpatient setting through the REDCap form. Paxlovid, which is our default agent, this is the one that we are encouraging providers to evaluate for their patients. This is a protease inhibitor. We recommend using it early in treatment and for high-risk patients that are tier 1 through 4 with a high rate of risk reduction of with this therapy. This is available outpatient only and not inpatient. Molnupiravir, this is also available, and this has a lower risk reduction, but is also available outpatient. And then lastly, IV Remdesivir, which we talked about. We are recommending that for early in therapy, and with the demonstrated benefit of upwards of 87% reduction in hospitalization, and this is only available in the inpatient. It's important to note, I notice a error here. This is for Paxlovid. They need to be within 5 days of symptom onset instead of 7. So what is here's the checklist for when you're considering therapy. You need to have a patient with a positive test. They have to have symptom onset within 5 days for orals or within 7 days for IV monoclonal therapy. They must have risk factors for severe disease, which can be found on the CDC website. And it's important to review the medication list and potential drug-drug interactions. For providing treatment, it's important when you reach out to patients that you discuss the oral therapies. And if you need, if your patient needs IV bebtelovimab, to reach out to the UW Medicine COVID-19 Therapeutics team, as we will help coordinate that if your patient is eligible. We also have some tools in EPIC, or the .phrase.covid19 oral therapy assessment, or .molnupiravir, to help you with some of these key inclusion criteria. And then you can prescribe therapy, as Shireesha showed, either at one of our UW Medicine selected pharmacies or at pharmacies in the community. So just a reminder to go over the UW Medicine COVID Therapeutics teams. We are reviewing all positive results within the outpatient system Monday through Friday. We specifically review and identify patients that are tier 1 or tier 2 to make sure that we can ensure equal access to therapy. We will evaluate these patients for IV bebtelovimab or oral Paxlovid, and we communicate directly with the patients or their providers to coordinate their treatment. Here is our team here, which is including not only clinical folks, but a lot of folks that are project management to help us keep up to date with all of the updates and the documents. We have lots of resources available to you. So the NIH COVID treatment guidelines, the FDA fact sheets. Also, the UW Medicine resource page has a lot of good information that links out directly to some of these primary references, such as the NIH guidelines, the FDA fact sheets, as well as the CDC. We've also created this UW clinical algorithm for treatment to help you walk through individual cases. We are constantly updating in this and reviewing this to look for additional ways to help you guys prescribe this. A lot of these boxes are hyperlinked. For example, this purple box here hyperlinks directly to the CDC website. This box here hyperlinks to the red cap, as well as all of those workflow documents are available and linked directly to this. With this, we'd like to conclude our presentation, and we will definitely take questions. Really want to acknowledge the hard work of our COVID-19 therapeutics team, as well as Kate Bialik, who let us use some of her slides and provided a great framework. So with that, should I stop sharing? And
yeah. We have a number of questions in the chat that we'll just start going through. I think Leo Morales brought one up that he brought up with me last week as well. Can you comment on whether, when, if ever, it's appropriate to prescribe Paxlovid without a recent renal function? And I think this really gets to people who are not necessarily in care, where we may not have labs. And so most of the patients we have who've tested through UW Medicine have had some touch point with the healthcare system, where we can see either in Care Everywhere or in our own lab system that they've had a kidney function in the last couple of years. But what if we don't have any of that information? My thoughts are, if they don't have significant risk factors that they're aware of, then it can be potentially used cautiously. Or you can use the alternative molnupiravir as an option if they're tier 3 or 4, for instance. And Rupali, do you have any other thoughts about that?
Yeah, I agree with you. I think keeping it in the framework of those risk factors for severity of disease, and whether or not you're willing to prescribe it without having that information.
All right. So another question is someone required to be a UW Medicine patient to receive either the monoclonal antibodies or oral therapies or even Evusheld? So Rupali, you want to answer that?
Yeah, so our pharmacies can fill the prescriptions for the oral medications. For non-UW Medicine patients, we will create a U number for them, and they can be dispensed. We do accept referrals for both Evusheld as well as IV bebtelovimab through the Red Cap referral. There is a little bit different. We need to collect some additional information, such as date of birth and things like that, if we don't have a U number, but we are able to accommodate those patients.
And then some patients have directly emailed our UWMMAB email to directly advocate for themselves to access therapy. And what we will do is refer them to either a test and treat location that they can just go to without a visit, or if they're not a UW Medicine patient, set them up with an urgent care provider. And our urgent care team at our neighborhood clinics has been an amazing partner in this, getting these patients in who are not our patients to review these medications and determine their past medical history, which is not as easy to do over the phone. If they're not a patient of ours, then we don't know anything about them. So they've been great partners in prescribing these oral antivirals.
Shireesha, did you want to answer the question about IV access? Considerations for, oh no, we already answered that one, sorry. Yeah. Let's see.
For patients who, there was a question that I already answered about if someone has gotten COVID, got Paxlovid, and they get COVID again, can they get Paxlovid again? If they're at risk, then yes, there's not a limit. I would just caution that this person actually truly has recurrent infection rather than just persistent positive PCR. So some patients we notice when we review our lab list of positive COVID tests that people are just testing again and again to see if they're cleared. But as we know, that molecular testing can be positive for some time. So someone's asking about a patient they saw yesterday who had COVID the 3 times since the pandemic started and is unable to be vaccinated due to vaccination allergies and they're immunocompromised. Would Evusheld be beneficial? Yes. So this is a person who we may not pick up on the list if their immunocompromising condition isn't readily apparent, but if they may be on our list to reach out to. So if they haven't gotten a letter from us, go ahead and put in that referral for considering Evusheld for this patient. One question is, will Paxlovid be available for less high-risk patients once the supply is better? And if so, would you recommend it? So that's a really good question. And I think it gets to the point of what is our outcome that we're looking for. So all of the studies, we were looking at hospitalization and death. In these patients where there's less high risk, what are we hoping to achieve? Because if they're vaccinated, boosted, they're not immunocompromised, their likelihood of getting severe disease, hospitalization, and death is exceedingly low. So are we looking, so someone asked about long COVID, someone asked, does it actually decrease the risk of long COVID? Does it decrease viral shedding? And can we look at it on in terms of reduced transmission? I think those are yet to be really demonstrated. And I will say that these are a lot of pills for people to take. And we, Rupali and I did a review of our first 50 patients who, with the help of pharmacy residents, who called these patients, and the side effect rates were actually quite significant. And about a quarter of people actually discontinued before the end of their therapy. So for patients, and they honestly, the people said, my COVID wasn't that bad, and these meds were horrible. So that's just something to consider, that they do have side effects, and if their COVID is pretty mild, what is the risk benefit? And so yeah, just considering that.
Shireesha, one question that's come up is, can we use Paxlovid for more than 5 days consecutively? And I think it's important to note the EUA was really only approved for 5 days. And so really limiting it to the 5 days. There are additional studies and things that that will be evaluated for longer courses, but at this time it's just for 5 days.
Yeah, yes, I think it's, some people might have heard that there has been uses within our system, but it's for investigational use to give it to severely immunocompromised patients to decrease shedding. But again, that's not authorized currently. There's a question about cost. Paxlovid currently, because it's an EUA medication, as well as bebtelovimab and molnupiravir, the drug itself does not cost anything. When we think about bebtelovimab, there is an administration charge that the patient will get, what we bill to their insurance for IV placement and actually giving the drug. But other than that, the drugs are all of no cost, with the exception of Remdesivir, which is, because it is approved, it is charged. All right. See here, there's quite a few questions.
There's a question. Oh, go ahead.
Oh, no, go ahead.
So there's a question about home testing. And if a patient is positive with home testing, if they do reach out to the provider, is there a way to forward the link to the UW Therapeutics team? And we really, one of the goals here is to really empower the providers to prescribe therapy for their patients. We are here to answer questions via secure chat or via email, but really want to encourage providers to hopefully feel more comfortable with these agents. As we know, COVID's not going anywhere. So we will need to continue to learn about and prescribe these meds.
Yeah, we're in it for the long haul here. And many of the resources associated with COVID-19 that we've had since the beginning of the pandemic are going away in terms of our national funding and other things. So in terms of how we can make this a sustainable process. We really need the partnership of all of the providers and staff at UW Medicine to be able to figure out, you know, within your own workflows, how does that work? And someone asked about nursing workflows, MAs being involved in this process. I think that's a great way. There's not a one size fits all for all the clinics. And so looking at how your clinic operations, is there a way to incorporate nursing or MAs or pharmacists that works in your clinic to help with this process would be great, because particularly for our tier 3 and tier 4 patients, we really don't have the resources within the therapeutics team to really offer therapy for all of those people. We're really focusing our efforts on tier 1 and tier 2 patients that and also patients who in those groups that have limited English proficiency, and we want to make sure that they're really not left behind in this process. There was a question about if someone who is non-immunocompromised, vaccinated, boosted, will be traveling for work to an area with limited healthcare resources, can we prescribe Paxlovid for them to take to this rural area or rural country? And unfortunately, no. We have actually gotten this question a few times directly from patients and also from providers. The EUA stipulates that it has to be prescribed to someone with a positive COVID test. So we are really, it's not to be given for post-exposure prophylaxis or pre-exposure prophylaxis, or to have on hand for in the case that you do get COVID. Let me look through here for any other questions here. Okay.
Was a question about pediatrics. Did you want me to share some of those resources?
Oh yeah, if you want to just share some of our extra slides.
Okay, so let's see. So one of the questions that was about what is available for pediatric patients, and neither Shireesha or I have expertise in pediatrics, but we can reach to our NIH guidelines that do say most children with SARS-CoV will not require specific therapy and usually can be managed with supportive care. Our friends at Children's have a beautiful pathway that's available and free to look at, and they had a nice pathway for what they for the options that they have for patients. Unfortunately, a lot of the data is for patients that are 12 and above, that lower end 6 to 12. Currently, there's ongoing trials of oral Paxlovid, but currently not approved for these populations.
Okay, there is a question about if you've received some of these therapies, is there any guidance about when to get vaccinated or boosted? And I would say that for Evusheld, that's the main one that there is some direct guidance. So this is the pre-exposure prophylaxis. Evusheld should not be given for at least 2 weeks after of the last vaccine dose. So you want to, if someone has been vaccinated, wait 2 weeks to give Evusheld. Other than that, there's not really any other contraindications. We used to have a recommendation to wait 90 days after monoclonal antibody therapy back when we had the Regeneron product. But that guidance was taken away several months ago. So there is no waiting period after getting bebtelovimab to get your vaccine. I think we've answered so much of them.
Yeah.
Oh, are there side effects similar for Paxlovid versus molnupiravir? That's a good question. The GI side effects were definitely not as apparent in the molnupiravir study as they are in the Paxlovid study. So maybe some better tolerability with molnupiravir.
we
I
will
think she
need
said we need to wrap it up
wrap it
for
up.
the hour. So thank you all so much for joining this session. Rupali and I are available. We want to support you through this process. So please don't hesitate to reach out to us if you have any questions. Or if you just want a second set of eyes to say, hey, does this seem right to offer it or to not offer it? As we are all getting used to this process, we're here for you. Thank you so much.